Good morning, everyone. Good afternoon, good evening, depending on where in the world you are joining us from. Today is day 2 of Utah Global Surgery Symposium, and we're very excited to have you all with us. Just a few housekeeping tips before we move into our keynote today. We just wanted to remind you that we are going to be using a couple different links over the course of today. This keynote and the first panel will both be on this link, so you can stay on after this keynote. And then we'll be moving into research presentations, oral presentations, the links for which are all provided in the email that was sent out this morning. And then also in that email that was sent out this morning, we have our video competition going. Voting will be open until the end of today's conference, so please do vote. In that link, you can also see the videos that were submitted and then vote for which one you think answered the prompt the best. And then finally, as for this keynote and the keynote that we have later on in the afternoon, we also have Spanish and French interpretation. To access a Spanish and French interpretation, please go to the bottom of your screen. There will be a button that says interpretation towards the right of the menu bar, and you'll be able to select which language we want to hear this keynote in. So without further ado, I will pass it on to Dr. Ray Price to introduce our keynote.
Wonderful. Thank you so much, Anusha. I was thrilled when I was asked to be able to introduce our speaker here. I was calling Dr. Roy because I could not, Nobhojit, in fact, he'll have to correct how I ever say his name. My friends that I've had for so many years, they laugh at me because I really mess up their names. But Dr. Nobhojit Roy, he trained as a general surgeon and trauma surgeon in Mumbai, India, and in the United Kingdom. But he also holds an MPH from Johns Hopkins University. And during his MPH, Catherine DeVries first introduced me to him as we invited him to come out and speak to one of our first global surgery meetings here in Utah back in about 2008. And at that time, he may not know this, but that talk he gave had great impact on me. It was a talk that was called Surgery in Resource Poor Settings, Wield, Yield, or Shield the Knife. And some of his information became part of my slide decks that I've used forever. When he taught us a Chinese proverb or philosopher from Lao Tzu said, go to the people, live with them, learn from them, start with what they know, build with what they have. But with the best leaders, when the work is done, the task accomplished, the people will say, we have done this ourselves. And I'd like to let him know that this has been something I have shared for the last 15 years now because of his talk here in Salt Lake City, and I'd like to thank him for that. He went on to get a PhD from the Karolinska Institute in Stockholm, Sweden on injury epidemiology, trauma registries, and health systems in resource poor settings. He was professor and chief of surgery at the Bark Hospital, HBNI University in India, providing universal health care to 100,000 people in suburban Mumbai. His department is the designated World Health Organization Collaborating Center for Research in Surgical Care in Low Middle Income Countries, which focuses on accessibility, burden of disease, preventable deaths, and outcomes of the NCDs. Therefore, he was the National Advisor, Public Health Planning and Evidence at the think tank of the Indian Ministry of Health and Family Welfare, the National Health Systems Resource Center. Currently, he is the Director of Health Systems Strengthening Team at Care India, which is the technical support and resource unit to the Health Department of the state of Bihar with a population of 110 million. Now, he's been one of the Lancet commissioners on global surgery. And I don't know if he knows this, but when John Miera called and asked me to submit 3 different names of people to consider, he was one of the 3 that I gave to Dr. Miera, both he, Gonbold, and Dr. Rodas from Ecuador. I think his experience is truly remarkable and has such a vision on surgery around the world. He currently is a trustee at Lifebox, and I consider him a very good friend halfway around the world. Thank you so much for being here. I'm going to turn it over to you. Thank you.
Thank you, Ray. Thank you for that fantastic introduction. It's wonderful to see you. About my first name, for my American friends, I just say it's no budget. And when you're working in global surgery, it works well, no budget. I'm going to start my presentation. And the way I've structured it is that I'm going to speak about global surgery and then flip between your world and my world, so that I am able to convey a sense of how global surgery is moving along. First, a disclaimer. Any resemblance to characters in global surgery are purely intentional and fully referenced. And no global surgery volunteers were harmed in the making of this PowerPoint, nor egos bruised. With that, the structure. First, I say that we've moved from charity to science, and from science, the current wave is about decolonizing surgery. I'm going to speak about careers and choices in global surgery, because this is a question I get a lot from the students, and they keep asking about the life in global surgery. So I'm going to speak about that. Then, of course, the training and the aspects of surgical ethics that go with a life in global surgery, and about impact and collaborations, so that we're able to segue to the next session on South-to-South collaborations. Of course, with a young audience, you can't help invoke Dumbledore, who is the ultimate teacher. And he says, "It is our choices, Harry, that show what we truly are, far more than our abilities." And with that, I can say that this audience has chosen, and the very fact that we are in this seminar together, it clearly shows that you have taken that choice of being in global surgery. But there are challenges, and this one, particularly this list, has been created by Doruk, my friend Doruk from UCSF, and my Nigerian brother, Emmanuel Ame. And what the challenges are, especially at your end, is that there's a perception by the surgical community that global surgery is mainly voluntarism. Now, the same voluntarism, looked at it from my end at the bottom of the food chain, we are looking at it as vacation surgery. Oh, people come and they do surgery and then they go away. The second is that there's a persistent perception by the public health community, because here with global surgery, we are stepping into the world of public health, we're stepping out of the operation theater. And they feel that it is a luxury activity and it's not a priority. Though that has been changing very much with the DCP3, with the Lancet Commission, and the WHO pushing that it's not a luxury activity. At your end, definitely there's an uncertainty of an academic pathway. So I keep hearing about that if there is no defined career graph, and it creates anxiety and concerns about career progression and also self-fulfillment. So they're all good people who start off on this career, but somewhere down the line, there are these challenges which start taking over. The world of academic global surgery has a focus on scholarly activity and publications. And the questions persist on whether global surgery work can have an impact in the real world. Of course, there's the issue of funding and who is going to fund this activity. And a university-based surgeon always has this challenge. And of course, there are inherent complicated logistics for the work and partnerships between different institutions, different countries. So is there a career, a trajectory? Are there enough role models? Is there institutional legitimacy, or is it more individualistic? These are the questions that we have to keep asking. And that, I thought, was one of the important career decisions that people end up taking. The characteristic features of the world I live in is a lower pay, physical and intellectual isolation, a family buy-in on the compromises that I am making. You move from grants to publications and WIIFM, and I'm going to cover this, what's in it for me. It does not count towards tenure while using your vacation time, precious vacation time, and global surgery never becomes your primary work. So in this scenario, how do we make this important? And of course, one of the things that we keep hearing is that you teach a man to fish and he fishes for a day and so on. And I'd like to use the fishing example about global surgery to understand the world of global surgery. And first, of course, you've decided to go fishing, which is great. So welcome. This is how I was surprised to see people fishing, and it's called fly fishing, I was told. And you take this, and I tried it once and twice. I got the twine all around me, and you had to wear gumboots, wade through the water to catch these trouts. And I was a complete failure because when you go fishing in my waters, this is how you fish. So I had my American friend come over and fish with me, and I realized that he wasn't able to throw the net out, which was like second nature to me. So while surgery remains the same, while the fish remain similar, while people remain similar, there are crossover skills which need to be learned. So this is how my operation theater list looks on a day. And of course, on the right is the handwritten operation theater list. And there's a wall below, and you just keep filling it up, and it goes to 20 to 25 cases a day for a single surgeon, very common. And you keep writing down the wall.
Just one brief, sorry, I'm so sorry to interrupt.
No problem.
The interpreters are just asking that you slow down a little bit.
Sure.
Just because Spanish and French have a lot more words. Thank you so much.
Sure. Sorry about that, Anusha. And feel free to remind me. So this is how my global surgery operation list looks for a day. And I would start this list by giving my own spinal anesthesia. We would do the first cesarean section without electricity, and that's quite normal. You would have a subdural hematoma drained based on clinical signs because the nearest CT would be about 200 kilometers away. You would reduce a Colles fracture. You would have one single X-ray plate. So you have a choice of taking it either pre-op, before you fix the fracture, or after you fix the fracture. It's normally open reduction. It's not open reduction, internal fixation. It's normally just by manipulation. Most surgeries, you would get paid $10, equivalent to $10. You could receive it in cash or more likely in kind. So you could get paid in bananas, and $10 can get you a lot of bananas, believe me. Your dermatomes would be razor blades. You would use mosquito nets as hernia meshes. Be ready for many anesthesia deaths should you opt for open ether or any of general anesthetics. And the only trained person that is assisting you today may be gone next month because there are greener pastures, usually overseas or in the more richer places. A Linköping study did a 15-year study, and they said that an average surgeon does about between 30 and 80 surgeries per year. And when I read that study, I said, oh, wow, that's a nice life to have, because you do between 25 to 30 surgeries in a day in my part, and still you have this unmet need for surgery. So global surgery means you go fishing together. And often the great way to start is to fish in calmer waters. And so you'll find that most global surgery is all about elective and mission surgeries. But that's not the way my world looks. And this is out of the Lancet Commission. And what you really need in LMICs is the must-do surgeries. These are acute, high-value procedures, which are usually limb or life-saving. In global surgery, we require year-round coverage, either through long-term engagements or multiple back-to-back short-term postings. That is what we would need to deliver this unmet need. Of course, what gets done are more the should do and the can do surgeries. The can do surgeries are the ones which require consistency, are usually demand driven, and they often distract from local priorities because it is easier to do cleft lips and cleft palates and cataracts and fistula surgeries, do elective prostates, simply because it's possible to schedule them. But the real big need and the lives that are lost are in the must do and perhaps some of the should do, which get delayed. So as you progress in global surgery, I would say that you start fishing again together, but you would be available for emergencies. And we haven't really got there in the global surgery world as yet. But this is what I see as the future, where some of the LMICs are having global surgeons and help from global surgery colleagues who are actually looking after these kind of needs. But this is commando training. This requires much more because it's really hard. You have to be a far more skilled surgeon when you know your nearest neuro or vascular consult is 200 kilometers away. It's just easier to be braver in a university hospital where you know you can reach out to your colleagues for help. So how can we do this? The way to do it is, of course, firstly, is to understand the culture. And for the culture, we would need 10 ways, 10 steps. And the first is you need to listen and listen to the people that you've gone and you wish to help, and in the LMIC surgeons. Second is listen. Third is listen. Fourth is listen. Fifth is assist. Sixth is listen. Seventh is listen. Eighth is drink beer or drink tea, whatever the culture allows you. And 9 and 10 is listen again. Now, I think we just cut short this phase of our global surgery training, and we are very quick in fitting in solutions, and which is why I think that we haven't made as much progress as we should have made. Typically, if we are good at a thing, if we're good at certain things, like you're good at vascular ultrasound, for example, you would want to come and teach vascular ultrasound because that's your comfort zone. But the starting point is not the needs. What's in it for us? I think if in the global surgery world, I can tell you that most people join and it's because they love travel. They like food, language, music, visual arts, festivals, games, dressing, a whole bunch of things which are clearly obvious, but at the deeper level, they value friendships, they value other people's religious beliefs, beauty, values, norms, exceptions, everything. So I think there's a whole host of reasons to be outside your regular comfort zone, because you're able to look at the world in a completely different way through surgery. I love this cultural adaptation curve. On the y-axis is your happy meter, your mood range from low, regular to high. And on your x-axis are the number of months, that is from 1 to 6. And as you come into a new place, into a new global surgery world, it is the honeymoon phase. And that lasts for a couple of months. And this is what I have experienced for the last 17 years that I've hosted fellows and interns, even before they were called global surgery interns. Then there would be humanitarian surgery, tropical surgery, mission surgery. They had many names, and global surgery has been through many names. And then within 3 months, there is a period of hostility between the locals and the visitors. Then you start coping, and then there is a fair bit of humor which comes in, and you learn to cope, adapt, and usually you cope with humor. And then by 6 months, you're definitely just waiting to get back home. And I found this cultural adaptation curve very interesting because most of us go through this. This is how the district level operating room looks. And what happens is that the WHO has flagged the district hospital as the key delivery unit for global surgery. This is the waiting area. These guys hanging around are my blood bank. So they are the walking blood bank because there's no real blood bank around. So the moment you would need blood, the village has been grouped and cross-matched. It's all ready, and you would bleed them live, and you would do a procedure called UDBT, which is unbanked, using of unbanked blood. Fresh, high-quality blood, not stored blood. Unfortunately, it's still illegal in the world because most of our HIV colleagues have got such strong and powerful, for a good reason, ways to use blood that actually in acute care we don't get blood, and blood banks are scarce. This is how it would look inside. It's very common to have two operating tables in the same room. I know people are at various levels of dressing up or undressing, but again, most of y'all who have visited LMIC theaters, you would find that the window AC is perhaps the only thing that you have, and if you don't have electricity, you don't have any air conditioning either. So that's very common. Would you really want to operate in a place like this is the big question. What about all the safety and precaution and sepsis? Well, that's the big question, the ethical dilemmas, and that's what we fight with every day. Are we going to be able to match the world standards, or are we going to just send this patient home saying that we can't do it? And you would be surprised to find some really old, this is of course from a London prescription from 1962, but it's very common for us to give these kind of prescriptions too. And there's whiskey, 1 teaspoon, lemon juice, 1 teaspoon, honey, 1 teaspoon, and take 1 teaspoon every hour if needed for cough. And while it's amusing, it's very common to mix the two, mix local treatments with modern science. Here is where I'll need Elena's help or Sierra's help because I can't see the chat box while I'm presenting. And for the audience, I had one question. It's going to take 10 seconds. It's just, how many in the audience are currently working or staying full-time in a district hospital anywhere in the world? And if your answer is yes, you just have to type yes in the chat box. But wait, the second part of the question is, how many in the audience work and stay full-time in a district hospital in an LMIC? In an LMIC hospital. And for those folks, you don't have to answer the first, you just have to write a big yes in the chat box. And while you're doing that, I will talk on and I will wait for Sierra to give me the results. As I said, the prioritization for us is must do, should do, can do. You'll see a list of surgeries there, and you can see that almost no surgical training anywhere in the world prepares you for this wide range of surgeries that we would need when there is one surgeon, like where I am, for between 1 and 2 million people. So you have to do a wide range of surgeries, and no surgical training really trains you for it, which is why upfront Haley Devas says, perhaps what you will be doing is more scholarly work rather than really pulling up your sleeves and doing the surgeries. There are 44 essential procedures which need to be done as per the WHO. And there are various platforms which are available for it. At the community level, there are 8 surgeries which need getting done, which would include extraction and drainage of dental abscesses, superficial abscesses, circumcisions, deliveries, 3rd stage, and resuscitation. And typically you would transfer them on to the 1st level or the district level hospitals. And here the bulk of surgeries are done. And you will see through this list that you require a lot of cross-training across orthopedics, gynecology, ENT, ophthal, and a lot of trauma and general surgery. And there are only 7 surgeries which are in the essential list, which have to be done at the specialized or the referral hospitals. You will find that most of global surgery revolves around these 7 essential surgeries that are done at the referral hospitals. It's obstetric fistula repair, cleft lip, cleft palate. There's a lot of rectal malformations, cataracts, eyelid surgeries, and a lot of known trauma orthopedics, which is done. Why is it that global surgery represents just these 7 surgeries as opposed to all the other surgeries that I listed out, which are limb and life-saving? Simply because this is within our comfort zone. And it's a great beginning because even these surgeries are relieving the local surgeons of the load. But often what happens is when you have a camp for these surgeries, a lot of the local priorities get shifted. And this remains a concern. I will stop here and ask Sierra if she has certain of the poll results.
We didn't have anyone respond in the chat just yet.
All right. Okay, so that sort of proves my point, folks, that most global surgery conferences actually don't even include those global surgeons who are out there. And I think that was the point of this poll, that we keep saying that the district hospital is the delivery unit. That's what the WHO says, that's what the Lancet Commission said, that's what the Global Surgery World says. And yet you will find, and I have attended so many global surgery conferences, and there is nobody from the real global surgery world attending these conferences. It is a concern for me. It has remained a concern and it will remain a concern, that how do we really include them in these global? So we are talking about them, but they are not a part of the conversation. Which is what brings us to what can we really do? And Candice Grimes is a young woman surgeon whom I respect a lot. I think she's in King's College now, but she was in the commission. And she said in global surgery, she had 9 recommendations. 1 is identifying partners, and the ones in red are for the younger people in the audience, and the rest are for the faculty. Second is understanding local needs and resources, training of local healthcare workers and ensuring sustainability, use of local and appropriate technologies and skills, monitoring quality of care, managing post-operative complication costs, looking at affordability. How do you sustain these global surgery initiatives, and working with local and regional training programs? And Haley Devas from UCSF and from the global surgery world, again, another respected person, shared his vision for global surgery in 4 domains. And he thinks that the larger global surgery world can contribute in 4 domains. One is governance and organization, education and training, research, and access to essential surgical services in low resource settings. So these are the 4 domains that where the rest of the global surgery world can work. I think the UTA faculty have done a good job of addressing the education issues. The problems are on the left column: lack of trainers, no defined curriculum, no competency-based evaluation, lack of subspecialty training, and a lack of funding. And I think these problems are being addressed, and they're being addressed in various ways by various faculties in HICs. And I think this is one big area of contribution for HIC world to the LMIC world. The second big area is advocacy. And for this, I would like to invoke Kotta, who has talked about leading change. And advocacy with the governments is something that the G4 Alliance does very, very well. And a lot of the student bodies do very, very well. It's, of course, how do you start a movement in global surgery? And why I think this is important for the younger people, it's simply because they are really good with social media and they're really good at whipping up a storm. The problem is, by the time you get to my age, you suffer from terminal skepticism. You have lost your teenager belief that you can change the world, and terminal skepticism sets in very quickly. And that is why we need a lot of young people. And the steps that Kotta had said is, he's got 8 mantras: establish a sense of urgency, form a powerful guiding coalition, create a vision, communicate that vision, empower others to act on that vision, plan for, and I like this very much, create short-term wins. Don't talk about how we're going to change the world in 2050. Consolidate improvements and produce still more change. And lastly, institutionalize these new approaches. The students, fellows, interns who worked with the Lancet Commission did a brilliant job in this. They were able to pull in stakeholders from all over. They could pull in governments, international organizations. They pulled in the Indian academia, professional societies, international academia, private hospitals. They pulled in the media, industry, and funding agencies. I think that is what is remarkable about being able to pull in all the stakeholders. And for that, you need to come outside the operation theater, and we need to come outside the world of the very hospital world that we live in. And I'm proud to say that the student community pulled this off, and it was the launch of the Lancet Commission, which I continue to work till today. The Lancet Commission had proposed solutions, which we spend the next 5 years implementing. We have to move beyond the OR, and the WHO has given these building blocks and a lot of processes, and it's a matrix, which I will not get into, but this is not a part of our surgical curriculum. And I think surgical health systems is perhaps the thing that is going to make a big difference in the public health world, because you can operate on only X number of patients a day. But when you look at public health, you're able to multiply that many-fold. So we have a systems approach for our WHO Collaborating Center Global Surgery Fellows. And based on that, I'm not going to get into the matrix or the details, but on the left-hand column, you will say, we match the high-income country competencies, whether it's research, epidemiology, registries, clinical management, and then we come up with a matching program for them. And that's how we think that we are able to do a good job of having a good global surgery experience. And so on and so forth. We have basic science research backgrounds. You could come from a training background or a health technology assessment background. You could come from a trauma nursing background. And that actually points out to the fact that we keep forgetting paramedics, nurses, ambulances, and a whole host of people. Usually it's only physicians that we keep meeting, and global surgery is a lot about getting the other people in. Again, here is a matrix where we combine the platforms of global surgery healthcare delivery with the various phases of delivery of care. We look at the partnering organizations and we look at the resources and come up with a better skill match so that you are ideally well utilized. But while we do all that, while the system works for you, I think it's all about managing personal expectations. And I started with this slide. Finally, you ask, what's in it for me? I hope we have some answers to what should I do? What can I do? Why should it be in LMICs? Should I take the starfish approach and throw it back into the sea and help that one person? Do I really have a risk appetite to get into all these ethical dilemmas? It's not about just the act of surgery. And that's my strong message. It's not about the act of surgery. And yet most of us have taken surgery or want to get into surgery because surgery is so much fun. And I'm not ashamed of that. But the point is that the act of surgery is only a small part of the whole part of global surgery. It's the non-operative aspect of surgery that makes surgery happen. And there is a lot to do with research, documentation, events. And somehow I have had a lot of global surgery fellows saying that managing events is not my job. I want to do surgery. And yet you have these events and you have a lot of south to south collaboration starting off, which are events either in the North or conducted by the North. So just because the North people who are more privileged have had the ability to travel to many countries, which my colleagues haven't been out of their states, leave alone their countries, because they can't leave their practices behind. You bring in that skill, that ability to be able to make a lot of people meet. Then the questions of replicability and scalability. A lot depends on supervisors, on mentoring, on translating, because we keep losing out on the people who speak French, who speak Japanese, who speak Spanish. And I think that's what this seminar is doing. Though we are a small cog in a big wheel, it's interlinked, and you've got to find out which part of the cog wheel you are. And I want to re-emphasize on the health systems approach. Finally, it's about trust, friendship, collegiality, and solidarity. And I think these are the human values that bring the global surgery world together. And that's how I have lifelong friends like Ray Price, like Catherine DeFries, because they are special human beings. And I think that's while you're giving up, while there are payoffs and while there are trade-offs, I think that's what keeps us together. And if I started off by saying there's a lot of intellectual and physical isolation that I feel, and that has been taken away over the years by the friends that I've made. And more so recently with this whole COVID epidemic, that you realize that it's so easy to be connected and to be able to reach out, to be able to take grand rounds with people across the world, and or do nothing, just ask them, so how was your day? Because there are very few people asking them how was their day. And of course, I have to end with Dumbledore again. And we all, Harry, we must face the choice between what is right and what is easy. And it's not usually the choice between right and wrong. We're very sure we're not going to do the wrong thing. It's always the choices between what is right and what is easy. And with that, I'd like to thank you for listening, if you have been, and over to you, back to you, Anusha and Ray.
Thank you, Dr. Roy. I'm just going to launch a poll about the question that you had asked during your presentation to see if anybody else wanted to respond that wasn't able to in the chat. And we'll leave that open for a couple minutes. But I did want to thank you so much for sharing your experience and your wisdom with us today. We'll open it up for questions now to the audience. So please submit your questions through the Q&A function on Zoom or in the chat directly to either Ilana or I. As we see the poll questions coming in, I'll leave it up for another 30 seconds. I wanted to ask, your talk impactfully demonstrated the lack of LMIC district hospital inclusion, both in academic conferences and committees making decisions about global work. How can HIC students create more equity in conversations around global surgery?
Thank you, Sarah. So yeah, absolutely. I think reaching out to medical colleges around the world, and I think we've started a project on that. We actually try and reach out to medical colleges around the world. And first question we're asking them is, what is global surgery? And it's surprising to hear the answers. And most people have never heard of it in the LMIC world. So it's never ceases to amaze me where we talk about global surgery and the real people are not talking about global surgery. So.
Great, and hopefully
thank you for the poll.
Our poll results here. A majority of our attendees have not worked in a district hospital, although we do have 30% represented from an LMIC here today.
That's great. That is very heartening. That's good news.
So our next question is also from the audience. So the question is, what are 2 to 3 resources that you would recommend to students to learn about the current events and present day status of global surgery?
I think, yeah, the references that I used perhaps are the starting points, because I still think, because I scan all the global surgery literature, and I think there are a few key articles, and these articles have been compiled by various groups doing academic global surgery, and that's starting points. Surgical ethics is definitely one. How do you adapt surgery to a new cultural context? The fishing examples I gave. And thirdly, it's about documentation. I think what students from the high income country do for us is, firstly, they can speak English, which is the current world scientific language. Second, they have been around the world where most of the people from LMICs don't have that choice. Thirdly, with no offense meant, but they come in with naive eyes, and being naive sometimes really helps, because we are lost among the trees and we've lost the forest for the trees. Whereas when you come in with naive eyes, it gets sometimes very annoying because of the simple questions that you ask, but it just forces you to look at it in a fresh way. When somebody says, in Madagascar, they do it this way, and in Ecuador, they do it that way. I don't know what is right and wrong, but I have seen them do it that way. And then that gets us to think, because we are never going to be, I mean, the South never goes to another South country because there's no funding for it. It's always the North which is going to the South. And with the North going to the South, they bring in the ideas and they bring in the people. But there's what the real contribution is when you transfer information and technical expertise from South to South. And often you are able to speak both French and English. So that's how you connect the Spanish speaking world with us. And I think I have more to learn from Mexico and Brazil and from various parts of Africa than I have to learn from the US and the UK. But then all my training gets done in the UK and the US, which leaves me in a way handicapped. Over.
Thank you. That was a very impactful answer. This is another question from the audience. Hello, Dr. Roy. In the present situation that includes COVID challenges, along with the challenges in surgery that you've already mentioned, such as electricity and staff migration, how do you or how can we teach the newcomers to deal with such situations? As a student, it's a point of concern.
Good question. Well, we have to do it, and that's what I'm doing. I mean, you really are going to do it for a very short time. And if you are like me, it's a matter of closing down the hospital or moving along. And you'll notice that in global surgery forums, we never talk about physician migration or nurse migration. That's missing. And more LMICs are losing all our surgeons, nurses, and to these countries. So you'll notice that there are these blind areas where nobody wants to talk about, and that needs to come into the conversation. And there's so much talk about decolonizing global surgery, but yet the real issues are still missing. I think COSEXA did a great job on this one, and they said, South Africa said that we will not poach surgeons from other African countries, because you already have a very low surgeon to population ratio, and they actually got it. And I think that was very responsible, because every African surgeon wants to go to the richest neighbor, which is South Africa, if not go overseas to Europe and other places. Now, I don't say it's only the responsibility of the HIC world. It is also the responsibility of the LMIC governments to have respect for people who stay back. Unfortunately, even in the LMICs, if you made it big in the US, you are definitely a superstar. And if you stayed back and you served the local population, clearly you were a loser. And if that is the perception, and it is only us to blame within LMICs, that we've set these artificial value standards that if you are in MGH or in Mountain View, you are made it in life. And if you stayed back in a district hospital and served the people who really needed it, you're not smart enough. And as I said, you need to be a much smarter surgeon to work without a blood bank, without a CT scan, without your neuro and vascular colleagues. It takes a lot of guts, believe me. And you don't feel like a hero at the end of the day, because you know there are so many lives that you could have saved should you have had neuro backup or a vascular backup. So I'm sorry, Anusha, I'm speaking too fast again. I tend to do that when I get excited.
Thanks for sharing your thoughts on that. Our next question is, could you please describe your role as a Lancet commissioner for global surgery? And then also kind of what career advice do you have for students who are inspired by the paper and inspired by your work?
I would say the Lancet Commission was life-changing. In a way, it gave me a chance to visit and meet a lot of people in the rest of the world. I met Pankaj Jani, I met Emmanuel Mallet, I met just all these wonderful people from different parts of the world, which I wouldn't. The other shocker was that 5 billion people don't have access to my services out of 7 billion people in the world. And while I was an accomplished surgeon, I was just wondering then what was the point of all my clever gastric resections and my Whipple surgeries, which I'm so proud of doing when 5/7 of the world don't even get there. And if they're dying of abscesses and dental caries and this, why am I feeling so good? Obviously, I had created an artificial value system for myself. Soon after the Lancet Commission was launched, I quit my job as professor in chief of surgery and I went full time into advocacy for surgery. And I realized that that's a thing that surgeons don't really want to do because it's simply because surgery is so much fun, honestly. And you want to stay and you want to do surgery every day. It just is high adrenaline. It's so much fun. And all these advocacy meetings with the ministers and ministry promoting surgery is so boring, but it needs to get done. You just have to drink tea all day long and hope that somebody listens to you.
All right, we're getting close to the end, so I'm going to ask one more question and then we'll wrap up. In your Global Scalpels episode, you mentioned that we can be preoccupied with redefining the problem in global surgery, like what you did with the Lancet Commission was the first start of it. But whether it's 147 million or 150 million unmet surgeries, how do you see the future of global surgery shifting to action?
Yes, good question. I think we're in love with the problem. It's also it's nice to be in love with the problem. You speak about the problem often enough everywhere, and then you almost start feeling that you've done something about it. It happens with all problems in life, not only this one. And it's the implementation of solutions which is so much harder. And almost all of us struggle with it on a daily basis. And I think what I tell every incoming global surgery intern or fellow is that ask yourself the question, what is the bare minimum you can do? And they would say, I'm going to resuscitate one child and save one life. And I say, that's good enough. And what is the maximum you can do, given your skill sets, time? And what you will achieve is something between the maximum and the minimum, but go out there and do it. And because I think we are redefining the problem, and it just starts looking so big that we actually stop taking that first step towards the solution. And that's why my matrix, nobody is too big or too small. I'm not looking for the most accomplished craniovascular surgeon or craniofacial surgeon. You give me a medical student and I can give you things that a medical student can do. And that's why the matrix is important for skill matching. Thank you.
All right, Dr. Roy, thank you so much for sharing your experience and wisdom. It's been an honor to hear from you this morning and learn from you. So with that, we are out of time, unfortunately. However, we'll invite Anusha to guide us on our next steps for our next session. Thank you so much.
Thank you for the invitation and all the best for your global surgery careers.
Thank you, Sierra. Thank you, Alana, for moderating that wonderful, wonderful keynote. Dr. Roy, as always, just learning so much from you. For everyone who is watching right now, we are going to take a few minutes to just switch over to the next panel. So just bear with us while we go through a little bit of shifting. In the meantime, I would suggest taking a little bit of time to go and vote for your video. The link will be posted in the chat shortly.